the audience is eagerly waiting for the most modern development in the field of otorhinolaryngology. So we'll be moving on to the symposium on cochlear implants. The speakers are Dr. Moinak Dotto, Dr. Arindam Das, Dr. Indranath Kundu, and Dr. N.V.K. Mohan. But first, I would ask the moderator, Dr. Amitabh Rai Choudhury, to come on stage and take over the proceedings. The chairpersons are Dr. Ramanuj Sinha and Dr. Devashish Bormon.
Hello, good morning everybody. In this 68th conference, the most attractive session we are going to start, that is on cochlear implantation. Our moderator is Professor Amitabh Rai Choudhury. He is one of the most eminent cochlear implant surgeon, not only in our state, all over across the India. So we can start our interactive symposium on cochlear implant.
Thank you, sir. First of all, a very hearty welcome to all of you to this 51st annual conference of our association. And the day has started very beautifully. I welcome Professor Ramanuj Sinha, sir, to come to the dais, please. The day has started very beautifully with the young budding ENT surgeons giving us an overview of how the dynamics of ENT is changing. And therefore, we would now go to a real hardcore subject, which is cochlear implantation. This is a this is a condition that we are fighting, especially pediatric cochlear implantation. We know so many children are born today with deafness, and the way we can treat them and fight this condition has changed remarkably over last 1 decade, especially so in the last three decades or so. So I have very eminent speakers on this panel, on this symposium. This symposium we have made slightly different in the sense we are calling it an interactive symposium because we are going to let the speakers set the context on the particular topic, not going into too much depth, so that we have enough time for a discussion. So it's a symposium come interactive discussion. It's a slightly new format for our association. I would invite all the speakers. I'll invite the speakers one by one, and then they can take place on the dais. First of all, I'll invite Dr. Moinak Dotto, who is from Kolkata Medical College, and he is going to talk on the basics. Before Moinak, please have a seat. I think I will invite all the speakers as well. Next speaker is Dr. Arindam Das, who is a cochlear implant surgeon from PG Hospital, the Institute of Otolaryngology, very young and budding otolaryngologist and ENT surgeon and passionate otologist. He has also written a book. I forgot to mention, Moinak is a very academic person. He is involved in reviewer and many journal issues. So he is a person who is very much involved in medical publications. So welcome, Arindam. Next is Professor Indranath Kundu, who is the head of the department of the RGCO Medical College, who is also a very eminent cochlear implant surgeon of our state. And welcome, Dr. Kundu. And last but not the least is Dr. N.V.K. Mohan. He is from private setup, and he has also been doing cochlear implantation. And he is also the immediate past president of Neuroequilibriometric Society of India. So with that, I would start. So this is a picture. So without wasting much time, I just want to throw this question to the audience. We all can appreciate that this child, unfortunately born with congenital deafness, has so much to speak to us. But are we able to understand what she is saying, except for her eye expression? We are not. And that is why it is a condition that we considered as a neurological pediatric emergency. So whenever we have a child with this kind of situation, this is no worse than a stroke or something. So that we have to really go on war front and fight them. And essentially, this fight is lifelong with this family of the children. So I would now invite Moinak to take us through the details of the workup of cochlear implantation. Thank you. And we are all going to try to speak for 8 minutes, and then we'll have a discussion.
Thank you, sir. Good morning. With what sir ended, and just starting with that note, that we are dealing with a deaf and mute child, a child with a special need, and therefore he or she is having a compromised quality of life, and it is the responsibility of the society to give him or her a productive life, a purposeful life, and also to reduce the economic burden in our society. So for this, we need to have a timely identification of the problem with the help of audiological investigations, hearing aids, and if the hearing aid fail, then ultimately we have to provide the cochlear implant surgery. That is the main criteria. Now, how to prepare, or how do we proceed with such a child when we receive such a child in our OPD? Now, first of all, we have to take a brief history of the child, birth history, family history, and the history regarding hearing loss. Age, the reason for the hearing loss, the type of hearing loss, onset, hearing aid use, the duration of hearing aid use, and immunization status, age appropriate. Not the cochlear implant specific immunization, but age appropriate immunization status. Followed by medical and otological examination, audiological investigations, radiological examination, pre-implant immunization, language assessment, psychological assessment, which includes the IQ testing, vestibular testing, and lastly, most importantly, the counseling of the parents or the caregiver. So essentially, it is a team approach, which involves the child, obviously, the teacher, the surgeon pediatrician, caregivers, audiologists, the speech language pathologist, and psychologists. These indications or the candidacy or the workup has been streamlined in the government setup by the ATIP scheme run by the National Institute of Hearing Handicap from Mumbai. According to that protocol, the preliminary considerations which we need to take care of is the age, that is between 1 to 5 years prelingual. This is the maximum children we get in this window period. However, they have also provision for 5 to 18 years postlingual or acquired hearing loss also. Bilateral severe to profound SNHL, little or no benefit from conventional hearing aids, approximately for 3 to 6 months of continuous uninterrupted usage of hearing aid with speech therapy. And for postlingual candidates, there are WRS score should be at least less than equal to 30%. This is the criteria. Now, how do we go to the workup? The most important thing for the workup, which actually overlaps with the candidacy, is the audiological investigations. These include an array of these audiological investigations. This is taken from the directives provided by the ATIP scheme. But actually, we don't use all of them. What we need, or what we do practically in the government setup, is the pure audiometry, if possible, under the age of 5 years, which is not that practical in that sense. Behavioral observation is very important, or behavioral audiometry, otoacoustic emission, and beta. And this should be ideally done with a trained audiologist. Now, this is a summary or a snapshot of what we go. First of all, the otoacoustic emission, bilateral, I refer. This followed by beta. The timing will be said by my next speaker. The beta typically reads that there is no identifiable peak 5 or obtained in either ear at the 95 decibel hearing loss, and so on. Followed by, if possible, a pure audiometry. Now, in any case, in general, the auditory threshold speaks that for children aged 12 to 23 months, it is less than 2 years, the hearing threshold for both ears should be equal to or should not exceed 90 decibel. For individual older than 2 years, the hearing threshold should be equal to or exceed 70 decibel. And the speech detection with best fit hearing aids in a sound field equal to or worse than 55 decibel. This is a general criteria that audiologists generally follow. This will be followed by the radiological investigation protocol. Now here, the HRCT and 3D MRI are essential. Now this 3D MRI facility is not always available in the government setup, but this is the thing they want from the ATIP scheme. This category mentioned 3D MRI is required. Now ideally, it should be a 3 Tesla MRI, preferably, so that we can get the idea regarding the soft tissue delineation. And cochlear nerve diameter also, that is regarding the cochlear nerve diameter, and the surviving spiral ganglion should be more than 10%. Now, as you know, that the inherent differences between the HRCT and the MRI of the temporal bone provides us with the characteristic information for during the preparation of the child, the bone resolution as well as soft tissue resolution. Now, generally, the soft tissue resolution is much more better with MRI, like the morphology of the cochlea, the superior semicircular canal, the patency of the cochlear duct, the internal acoustic meatus, the vestibular aqueduct, cochlear nerve. All these pathologies can be well identified by the MRI. Whereas the HRCT provides us with a much more bony details. For example, the details of the cochlea, any cochlear malformation, which may determine the candidacy of the child, abnormalities of the oval or round window, the Philippine canal abnormality, which may be helpful or which may be deleterious for the surgical procedure. Now, this should be followed by the speech and language assessment, very important, which should be done ideally by a trained speech and language specialist. The assessment of the speech and language development in children and the speech language skills in older children, including articulation, voice, and language. And there are special sets. I am not going into details in here. Prelingual children, 3 subsets, Craig-Lib inventory. There are many such things which is specialized by the speech language pathologists. Now is a psychological workup. It's also very important because it is ultimately the intelligence of the child is a matter of question. How much the child can pick up the response to an outcome of a cochlear implant procedure in the long term. So IQ assessment, the intellectual ability of the child, these are important factors which will ultimately affect the child in the long term. Also very important is the family issues, because these children are basically born with some sort of a handicap, as the parents sometimes think, or the society sometimes think. So they may be subjected to stress, abuse, depression, and so on. Now, ENT assessment. First of all, these children will come to us, to the ENT specialists. We are the first or a point of contact physicians or surgeons who will encounter these children. Now, as we know, we have to first of all evaluate or send these children to specific investigation protocol to the pediatrician, to the speech language pathologist, to the radiologist, and etc. And we have to also investigate or examine the ear. Now, many of these children may have otitis media or many other infections in the middle ear. Now, it's not a contraindication as such. It's very important to note the children with active middle ear infection is not a contraindication. We should wait for subsidence of that the disease should subside, and then we have to wait for the implantation to take its course. A very important point which my earlier speaker Rahul told, that we have to read the imaging on our own. It is very important because the CT scan or the MRI, irrespective of what the radiologist give, for medical legal documentation is okay, but we have to read or go through or interpret the imaging on our own regarding the status of the cochlear nerve, regarding the Philippine canal position, all these things. So it's very important to read the imaging by our own. Now the interdepartmental liaison by the neuromedicine, pediatrics, ophthalmology, and so on, so as to find out or rule out any other developmental delay or any other deficit the child may be suffering from. Now the pre-implantation vaccination, this should include typically the Haemophilus influenzae B, the pneumococcus, and the meningococcus, ideally within the 1 month of the implantation procedure. If the child more than 2 years of age, if there is no previous immunization, we will give 2 vaccines in 1 month apart, and if he or she is already immunized, then 1 vaccine within 1 month of the procedure. And lastly, very important is the counseling. This counseling is of utmost importance for the parents and the caregivers, so that they have a realistic expectation of what is going to happen after the implant. It doesn't mean that once the implant is done, the child will start to able to hear and speak from the very next day. So it's a long-term procedure, and the speech therapy and follow-up is very important, and also important is to take care of the implant itself. So need to be informed regarding the potential risk and benefit of the cochlear implantation, a brief, very outline detail of the surgical procedure depending upon the understanding of the parents, and information regarding the post-surgical programming and rehab procedure, and special care for the implant. So this should be done with the ENT surgeon, with the speech language pathologist, and there is a definite pre-cochlear implant counseling kit provided by the NIHH. And Lastly, we come to the final logistics, what we essentially need to carry on this cochlear implant program successfully. An empaneled hospital, facility of hearing test, speech and language pathologist, facility of imaging, liaison among the departments, equipped operating room, instruments and microscope, and finally, obviously, the empaneled surgeons and painter. So,
that was wonderful, commendable for Moinak to cover such a vast topic in such a short time. So we have understood how the workup has to be done. It's a long process, but he has put it down in a very salient features. I would now invite Dr. Arindam Das for talking about the need for early intervention and what we call normally it's said early intervention, early detection, early intervention, but we are calling it early detection, earliest intervention, because as we said, it's a neurological emergency, and therefore Arindam is going to take us through the need for early diagnosis and earliest intervention. Arindam, please.
Good morning, everybody. At the outset, I want to thank UIO's Bengal organizer and my mentor, Professor Amitav Rai Chaudhary sir, for giving me this opportunity to speak in this forum on this niche topic. And one of the beautiful topic I have given is early diagnosis and earliest intervention. Today, the cochlear implantation in pediatric populations is increasing like anything. The numbers are increasing day by day. The centers are getting impaneled in everywhere. So we have to understand how early the diagnosis should be done and what kind of intervention should be started when we have diagnosed that the child or the newborn having some type of hearing loss in these cases. So we called it a medical emergency. And truly, it is a neurological emergency for the child. When a newborn born with a congenital hearing loss in the form of very moderate to severe range, then there is so many things that is going on inside the brain, and that is important to understand why we need to start the diagnosis protocol and the intervention earliest, so that we can help the child and change his or her life. So early diagnosis or intervention is very critical for successful rehabilitation and outcome for the people with hearing loss, whether child or adult population. And delays have a negative impact on language development. And why this is the language development or the development in general in the child is become defective when there is a delay in intervention, we'll going to discuss in next few minutes. Since the hearing loss is invisible, the main problem lies here. If the patient presents with a cardiac arrest or any road traffic accident or anything, we can understand there is an emergency, we have to rush to the hospital, do some emergency operation, medical management, whatever. But when a child born with a hearing loss, it is very difficult to diagnose the case in the early months of his life, and that is the main problem in the treatment of these children and going for the cochlear implantation. The most important thing is the auditory deprivation. In congenital hearing loss, the auditory deprivation start actually in the intrauterine life, because from the myth, that's the Abhimanyu, we know that the hearing starts from the intrauterine life itself. So when we judge a patient that the age of the patient is 1 year, that means the auditory deprivation is more than 1 year, at the 3 or 4 months more than the actual age of the child. And prolonged auditory deprivation actually affects the development of the brain and the auditory cortex and formation of the actual skill for the children in terms of cognitive improvement or any communication skill. So that is why the effect of auditory deprivation that has been studied by worldwide by various models, and this is called cross-modal plasticity or the neuroplasticity in the say, and this is the adaptive change in the drive of the neurons from one deprived sensory area to the another non-deprived sensory area. That means when there is a auditory deprivation or child is not getting any hearing input through the ear, the auditory cortex is basically encroached by the visual cortex. This is called neuroscavengering. So that means the auditory cortex is basically blocked. So after some time, if we tried a lot to give some auditory stimulation to the child or anything, that will be very difficult to understand for the child, and the development will be defective. And the same thing is the neuroplasticity. There is the organization of the neurons inside the brain, and this is the most crucial part to understand why implantation is needed as early as possible for the children, and why the age and the time of implantation is most important factor or the crucial factor for the development of the speech and language after the implantation of the surgery has been done. And this is called the critical period of speech and language acquisition. That is actually 3 to 4 years. Within this 3 to 4 years, the neuroplasticity of the brain is in the highest part. So if we can give the hearing stimulation to the child within this period of time, then there will be the maximum improvement, and the child will live his normal life for the rest of his life. So this is the landmark paper published by the Nicopols, that the age of implantation, and that shows that the neuroplasticity and the age of implantation is most important factor among the various factors that plays a role towards the this cochlear implantation. Now comes to the early diagnosis. So now we are following the Joint Council of Infant Hearing or JCIP protocol, and that was previously told us that's the 1, 3 and 6 month protocol. That means the screening should be done within 1 month, the diagnosis should be confirmed by 3 months, and the treatment should be completed by 6 months, or at least started by 6 months. But now we have moved from this protocol to 1 month, 2 months and 3 months protocol. That means the screening should be completed by 1 month by OAE. Everything has been described by Dr. Moina. And by 2 months, the diagnosis should be confirmed. And by 3 months, we should start the intervention by means of either hearing aid or in the cochlear implantation. So the unaddressed hearing loss is a very important part of the congenital hearing loss, and the newborn hearing screening is the most important thing we have to start worldwide, and this universal hearing screening can decrease the actual time for the child or the implantation time. So we have already discussed the 1, 2, 3 months intervention. The first, in 1 month we have to do the screening. Second month we have to confirm the diagnosis by the diagnostic beta or other behavioral test. And by 3 months we have to start the intervention. So what kind of intervention we should start? First is the auditory stimulation or rehabilitation by the help of hearing aid or cochlear implantation. Now at this age cochlear implantation is not done. So hearing aid is the main thing at the 3 months of age. And the most important part, after giving a hearing aid at this age, we have to regularly check the child for any improvement. And there is not such thing that you will use the hearing aid for lifelong or 3 years, 4 years, and then we will judge. Maximum 6 months of usage of hearing aid, and then we have to go for the aided audiogram to check whether this hearing aid is giving some benefit to the child or not. If there is no benefit, then the next part is the cochlear implantation, for which we are all here to discuss so many things. So now is the most important, the FDA approval that has been granted in 1990 for pediatric population, and it took 10 years to come down the age at the 12th month, and then it is 2020 when the FDA has approved the 9 months of implantation for the bilateral cases. Now where do we stand? So as a institute, we have already done more than 200 implantation in government program, but the age of implantation below 2 years is rare in our case also, and the average implantation age is 3.5 to 4.5 years. Sir, 1 minute. After 5 years of age, the proper speech and language development is very, very difficult for the child. And here we have two videos just for you. One is the child, they have implanted as 4 years. So the fantastic improvement, but still there is a problem in speech intelligibility and the clarity of the speech. The understanding of the speech is very difficult. But this is the child, the lowest of us that we have implanted at the age of 1 year 8 months.
আমাদের পয়লা জুলাই ডক্টর স্টে ডক্টর বাবুরা আমার প্রণাম নেবেন আর ভালো থাকবেন
So such a beautiful voice, clear speech, everything is there. So this is the difference. So next slide. So with this video, we want to conclude that the early implantation gives the best opportunity to improve the speech and language outcome or development skill, and it is the most important factor. And we have to bring down the age of implantation in our state also, because this is a very important challenge for us. And through all of you, I want to give this message to whenever you will get this such patient. So treat as a emergency condition and progress according to the protocol, so that the age of implantation can be reduced into the less than 12 months. So we say that today is always better than tomorrow for cochlear implantation. Thank you. Thank you all.
Thank you, Dr. Arindam Das, for making the point very straight about the need for the early diagnosis and early intervention. When we talk to our patients in vernacular language, we tell them just about this neuroscavenging is that আমি বাংলাই বলছি, আমরা পেশেন্টদের বলি যে আপনারা যদি একটা সন্দেশখালি বা কোনো জায়গাতে একটা জমি কিনে বাগানবাড়ি বানাবে বলে কিনে রাখেন আর 5-6 বছর ওখানে কখনো না যান, 5 বছর পরে হঠাৎ ওখানে গেলে আপনি দেখবেন যে আইদার ওখানে একটা মন্দির, মসজিদ বা ক্লাবের, ফুটবল ক্লাবের বাড়ি হয়ে গেছে, ইয়োর ল্যান্ড ইজ গন। সো সিমিলারলি অডিটরি কর্টেক্সটাকে যদি আমরা ইউটিলাইজ করতে না পারি, then we are not going to get back the hearing, and so auditory cortex will be taken over by the neighboring areas of the brain, and that's the point Arindam has made very strongly. Thank you very much, Arindam. We will now go to some philosophical and logistic issues. Professor Ayan Kundu, who is a very senior person in our MES. So Dr. Kundu is going to take us through the challenges, because he has been in the government setup, and it's not easy to set up a cochlear implant program, and he has done, so he's going to take us through the challenges.
Good morning to everyone. At the outset, I thank AOI West Bengal for giving me my opportunity, and it's my great pleasure to join in Amitabh's Symposium. And he is, in one sense, when I started the program in Arjugar Medical College, I started many giants in cochlear implant surgeons all over India, but ultimately Amitabh taught me many things. And whenever I was in trouble, I rang Amitabh, and he gave me valuable tips so that I can manage the surgical situations. Okay, now the challenges. Basically, the burden of deafness that we are facing now, about 360 million of worldwide people are having a disabling hearing loss, and 5.3% of the world population. The children constitute nearly 35%. And in India, 63 million people are suffering from severe to profound hearing loss, and it is about 3 to 4% per 1,000 live birth. So the problem is immense, and the burden is very much. Now, what are the challenges for implantation or to carry out the cochlear implantation program, either in private institute or in medical college? First of all is the awareness. Now, the awareness among the parents, awareness among the general surgeons, among the general physicians, awareness among the pediatricians, awareness among the ENT surgeons also. So the awareness must be there, public awareness program must be there, so that we can catch the children at the neonatal period and just after birth. Okay. Now, next is the infrastructure. It is a great problem, because almost in all government setup, we are having OE facility, BERA facility, but still now the high-risk population is being screened, and normal newborns are not being screened in many centers, even in Arjikor Medical College. Next is the expertise. Already it has been told that the speech pathologist or the audiologist must be trained, but sometimes in OE report, many faults are there in a neonatal unit where there is excessive sounds or the meconium in the ear. Many times we find that the OE report is reported as refer, but it is actually not the refer. It's normal OE report should be there. It should be passed. Next is the team. Yes, the team constitutes the ENT surgeon, the pediatricians, and speech pathologist, and the speech therapist, and so on and so forth. But team must be there, and dedicated team must be there, basically. And the last point is the funding. Funding is a great issue because the implants are costly. Governments, by EDIT scheme, they are giving out the implant, but it is not adequate. And the state government is not in a position to give the implants to all the medical colleges. They are giving some implants to PG, and we are not getting still now. Next is it's a long process, definitely from diagnosis up to the development of the speech and language is a long process. So we must have some patience to make the child speak. Next is the awareness. Awareness is a key issue. It must be, the pediatrician must be aware, and the general physician must be aware, the audiologist and speech specialist must be aware, and the society must be aware of the neonatal deafness. And many camps should be there, many and in the medical colleges and in the private setup, even in the clinic, the camps should be there to assess the hearing of the children. And we have already discussed that what is the results in late detection. The brain will be plastered, and even after implantation, the speech development will not as we expect in all the cases. Now, what are the reasons for delay? The main reason is the lack of universal neonatal hearing screening program, and it is lacking everywhere. And next is the lack of infrastructure of high-risk screening. Next is the lack of registry. Once the child is diagnosed as a hearing impaired, but he or she is being lost. And that is one of the things that we are going to face in our government institute. And the lack of uniform access to healthcare, and the private healthcare, it is very expensive. So the people are not able to get the implantation in private institute. And lastly, the ignorant society. Now the training should be aimed to the audiologist regarding the diagnosis and regarding the hearing aid and regarding the how to fit the hearing aid, what should be the hearing aid, and all these things. Next is the pre-implant therapy. Yes, sometimes we are giving implant to the kids. Sometimes we are giving hearing aid to the kids, but the pre-implant therapy is very much lacking. So again, the brain is being plastered, and we are not following these candidates properly. Next is the post-implant therapy. We know that dedicated post-implant therapy centers are very much lacking in our West Bengal. So even after EDIP scheme, we are giving the implant, but the outcome of the language is very much poor. Next is the psychologist and the parents. They should be also trained. The parents should be trained, and the expectation, regarding the expectation, we must counsel them. And lastly, the ENT surgeons must be trained. By the grace of God, we have got EDIP scheme, and after EDIP scheme, many ENT surgeon has been trained, at least in the government medical colleges. Because in our student life, we saw the cochlear implant surgeons from a distance. They move about their cochlear implant surgeon, and we are not doing any surgery. We do not know anything about the cochlear implantation. And by the ADIP scheme, we got the implant, and we Bangla bolle hat pakate perechi, and we have become independent cochlear implant surgeon by the ADIP scheme. And the next is the funding. Mostly in our state, it is being self-funded, but all the people has not got this access. And next is the central government ADIP scheme. That is the mainstay. That is the main thing of our funding in our state. And apart from that, the railway, army, CGHS, state government are the funding agents. Sometimes the NGO is coming forward to fund. Now, we have done at least 30 cases of cochlear implantation in Arjigar Medical College by ADIP scheme. Now, what are the shortcomings? The shortcomings are lack of independent rehabilitation center. They are not having independent rehabilitation center, and they are sending the patient. We are sending the patient here and there, and the standard is not maintained. And smaller centers sometimes do better, but the dropout rates are very high. And the post-implant funding, the maintenance therapy, and is very much lacking. 1 or 2 of my patients have lost the external unit while traveling in the train, but they are not in a position to purchase the external unit. And sometimes when the ADIP scheme started, the Neurolec was the implant, Neurolec company supplied the implant, but their all spare parts are not available in the market. So that is another problem. And these are the processing time, delay in surgery, these are the things. And private funding program, universal neonatal hearing screening program, high risk hearing screening, early detection, early intervention, and early implantation should be done. And these are the, in West Bengal, following are the centers in West Bengal regarding government centers, PG, Arjikor, Medical College, BIMS, and Railway Hospital, and other private cochlear implantation clinic, and the centers are like CMRI, Medica, Apollo, so on and so forth. Now, what is the future? The future is bright, I must admit. Many our new budding cochlear implant surgeons are coming day by day, and the centers are become equipped. But what we should do, and what we should need to do at present, in absence of universal newborn hearing program, the early diagnosis and intervention remains a challenge. Targeted screening should be done at the high-risk infants, and dedicated audiologists and speech therapists must be there to deal with the cochlear implant patients. And these are the references. And last one, I will not take too much time. And thank you all for your patience hearing.
Thank you, Professor Kundu, for taking us through the journey of sharing the challenges that we have. May I invite, because we are running short of time, may I invite Dr. Mohan from CMRI, who is going to take us through the surgical aspect, and especially for the benefit of the junior aspiring surgeons, how to become a safe cochlear implant surgeon. Thank you, Mohan. I would request to wind up in time, so that we can have some
Absolutely. Thank you, Amitabh. Thank you, AI West Bengal team, AI, for giving me this opportunity. Without much ado, let's just get to the thick of things. I'm sorry, I could not rearrange this properly. The basics. The one thing that you want to do is you want to have a good night's sleep, so that your hands are rested, your mind is rested, and your hands are steady. And for people who love their drink, like me, you avoid alcohol the previous night. So you don't want any kind of tremor to be there on the day of the surgery. Check your instruments. We've burned our hands sometimes. This drill not working, that's not working, etc., etc., and that loses precious time, and you tend to get agitated. And one important thing that I've found is having adequate rest for your forearms. Your elbows and arms are rested adequately, so that any fine tremors are not transmitted, especially when you're inserting the electrode. The electrodes can be very wiggly, and it might be a bit of a problem trying to negotiate it to a small cochleostomy.
The incision, whatever incision you choose, a straight incision or a lazy S incision, the crux of the matter is the skin incision and the mucoperiosteal incision should not be in the same line, so that they do not overlap and there's less chance of exposure of the device. The skin incision should be at least 1.5 centimeters anterior to the anterior-most aspect of the receiver stimulator package, so that the whole receiver stimulator is covered by a good thickness of mucoperiosteal flap. Placement, it's at around 45 degrees to the horizontal plane, right? And the anterior edge about 3 to 4 centimeters from the bony canal. We've covered that. Steps, we all know, small, cortical mastectomy with enough bony overhang so that the extra lead wire can coil there and get support, does not come out anteriorly. The one important thing is when we are doing this, apart from obviously, exposing your landmarks, which is the most important landmark here is the short process of incus, thinning of the posterior canal wall, that is a very vital thing, how it helps you, identify where your facial nerve is, where your chorda tympani nerve is, where your annulus is. You shouldn't have actually to identify the annulus, but doing that gives you greater confidence. And also, sometimes if you haven't thinned the medialmost aspect of the posterior canal wall, then after you've done the posterior tympanotomy, your view of the round window niche area might get obstructed by that extra bone. Then you have to again come back and drill that. So thinning the posterior canal wall is a very, very vital step. So in fact, if you can see here, we can see the chorda tympani nerve there. Somewhere here was the facial nerve, right? I couldn't edit this video for a very long while. The posterior tympanotomy dimensions, where do you get the maximum width of the posterior tympanotomy? That's about, 3 to 4 millimeters from the short process of the incus, right? From there. And the maximum width that you get is around 3 millimeters in the Indian population. This was a wonderful study by Shraddha Jain et al., right? And the width at the level of the round window was somewhere around 2.65 plus minus 0.4 millimeters, right? So if you are having some certain difficulties, so this is the region where we are going in. If we are having certain difficulties viewing the round window niche, we can take down the incus bar, right? And that gives you more superior angle from where you can look at the round window niche. And sometimes you can also have to extend the dissection downwards, sacrificing the chorda tympani, which is the extended, facial recess approach. Now, this is something that is a bit dodgy because nowadays we are doing bilateral cochlear implantations, and if you are, injuring both cochlear, chorda tympani, you're going to give the child a hearing life, but tasteless life. That's very sad. And even then, you have to preserve, even if you're doing one side, you have to preserve that. So that's probably the idea now. One quick thing about the orientation of the facial recess. So if you look at that, this is the bone that we are drilling to get into the facial recess, right? So look at the orientation. It's more kind of in the horizontal plane. It's, or should I say, it's in the coronal plane, right? So the drill should be directed almost vertical, parallel to the posterior canal wall. Look at here. This is the facial recess. So it goes like this, not like this. When you go like this, then you are liable to sort of hit the ossicles and cause dislocation and other problems. So that's one thing. Round window insertion or cochleostomy, the jury is still out on that one, but round window insertion seems to be more physiological, and it directly opens into the scala tympani. So you are more sure that you are entering the scala tympani. And there's less bony dust, obviously, and the electrode is closer to the modiolus and the spiral lamina. That is a reason why there could be greater injuries if you are not very careful. Now, we'll come to that bit in a bit. In cochleostomy, there's bone dust, there's acoustic trauma, and greater chance of interscalar migration because of the angle. Now, here, one thing that you have to realize is when you're sighting a cochleostomy, it's not always possible to do a round window insertion if the anatomy is not favorable. So when you're sighting your cochleostomy, it should be anterior-inferior to the round window membrane, not anterior. See, if you look at this, this is the osseous spiral lamina, right? And this is the hook region. It makes a turn there. So if you go directly anterior, then you're going to hit the spiral lamina and cause problems. So that is why it should be anterior-inferior, right? Insertion speed is one thing that you need to take care about is the speed at which you enter. See, when you are entering the scala tympani, you are actually displacing the perilymph. And when you're doing that, if you rush in, then you're going to cause greater movement of the intercochlear structures, the basilar membrane, and you can cause trauma. And you'll also probably have an interscalar migration. So speeds, you should be slow in inserting. That gives you less chance of injury to the intercochlear structures. Minimum 1 to 2 minutes. What I do is, when I'm ready to insert, my hands rested, the electrode is in my hand, I'm at the cochleostomy or the round window membrane. I ask my staff to start the stopwatch and tell me after every 15 seconds. So you gently insert, slowly and steadily, no jerky movements, right? And there are a number of studies that show, increased insertion speeds causes greater forces generated within the cochlea, and that can give rise to, injuries. The insertion angle, that is again very, very important. You have to realize that it has to be almost pointing towards the anterior hypotympanum region from a superior angle. I'll show you that in a bit, because that's how the scala tympani is oriented. It's not directly into the round window membrane. And some electrodes, even the straight electrodes, they have a slight curvature. If you have a slight curvature, that curvature, the concavity should face superiorly, so that you are that's directed towards the modulus, so that you take the curve of the scala tympani. So if you look at that, that is the hook region. Look at how the spiral lamina and all the compartments make a 90-degree turn here. So I'm sorry. Yeah, I'll be as quick as I can. So look at that. So this is the direction you want to go in. You go in this direction, you're going to hit the spiral lamina, right? And this is this thing about the orientation of the modulus. So like I was saying, it's a cone. The tip of the cone is pointing towards the anterior epitympanum. Anterior epitympanum. So that's what you need to keep in mind when you're inserting the electrode. The short video, I think I'll do it. I'll rush it through, Amitabh, with your permission, right? Yeah. So this was a revision case that we were doing, and at the entry. Okay, see how wiggly it can be, and when you are doing it on a magnification, even a slight tremor gets magnified. So there, and now you slowly insert, take your time, I'll fast forward this. Okay, so this took me at least about 1.5 to 2 minutes to insert. Hearing preservation, this is the last slide, I think. So low drill speeds are very important, so that you don't touch the ossicles and injure any, hamper any residual hearing. Good irrigation to remove all the bone and dust before you are ready to open the scala tympani. Soft entry is always preferable. So you leave the endosteum. If you're doing a cochleostomy, you leave the endosteum, and if you're doing a round window incision, you clear everything, and then you make a sharp cut on the round window membrane. Remove the whole of the round window membrane so that you facilitate egress of the perilymph when you are inserting the electrode. Otherwise, the pressures will increase and cause intracochlear damage. Slow insertion, the correct angle, like I was showing you, and a thinner electrode is always useful in this regard. So tie down sutures, keep enough distance between the holes, and bevel them. Shoulderless burrs to actually connect the two dots, I think, two wells. I think that is important, because otherwise sometimes, it thins out the outer cortex so much that when you're trying it, then can break through, right? And take care not to injure the dura. So it's more a ballet, so you need to, be more graceful and all of that. Thank you very much.
Thank you, Dr. Mohan. We have learned how to become a safe and judicious surgeon. We have about 15-20 minutes time left for the discussion. We'll quickly go through the discussion. I think most of us have now have a good grasp, especially for the beginners who want to take up this subject, have a grasp on how to select cases, which are the patients to be operated, how to prepare them, how to work them up, what are the challenges we'll face during creating a cochlear implant program, and then what is the need for early detection and intervention, and finally the surgical. All the speakers have done wonderful in terms of the time and covering of the topic. I'll just quickly run through a few questions, because the idea was that one speaker speaks about something, we do not get the benefit of the knowledge of the other speaker who is speaking on a different topic. So we get opinion of the other speakers. Screening, I think Moinak has told us about the screening. I would start with Dr. Kundu. What is the modality of screening in your institute with the existing facility? We just want to understand where we stand today. And then we'll go to a private institution also.
In our institute,
In a very nutshell, yeah.
yes, mostly the high-risk cases, those newborns are admitted in NICU, they are being screened by OAE.
Hey, you carry
And
on.
if it is referred, then again the patient after discharge is asked to attend our ENT outdoor after 1 month.
So that's so essentially there can be two kinds of screening, as we know, high risk screening and universal screening. Universal screening does not exist everywhere, but which is ideal. Coming to Dr. Mohan, so RGCOR or many of the medical colleges currently are having a high risk screening. So we screen those people with a newborn hearing or other things who we think are susceptible to or likely to have a congenital deafness. In our private setup,
We are
What
screening all children who are delivered in our hospital.
you have,
or take us
so
to-
smaller private hospital, many of the private hospitals in the city has the facility of universal. So a child is discharged, goes with a OAE certificate before the child is discharged after delivery or cesarean, whatever, including Neotia, MRI hospital, I think CMRI, many other hospitals. Even my institute, VIMS, we have been able to do that. But challenge, I think, coming to PG and medical college, what is the facility?
We have the facility for screening the patients, but all patients
High
are not.
risk.
Only
Again,
the
high
high
risk,
risk.
huh.
And in the state of West Bengal, we have already started the SNCU setup only. The screening on the SNCU.
SNCU.
Only the high risk setup. And that was a very difficult to start for last 2 years also. But universal hearing screening
So
and
that
very long.
itself is a milestone, because we are going
Yes.
to pick up those 4 to 5 children born deaf can be picked up even with a high risk screening. Moinak, from your
The
institute?
same in the medical college also, only the high-risk neonates are sent to us by the from the well baby clinic for screening, with starting with OAE and so on.
So the
Not
need of the
universal
hour
screening.
is to set up a universal neonatal hearing screening in the state. So any message goes out from this, any policymakers, please carry this message that we do need a universal neonatal hearing screening at all hospitals, super specialty and medical college in our hospital. That's the need of the hour.
One thing,
coming-
Amitabh,
Sure, sir.
not only the medical colleges, in the peripheral hospital also,
District, yeah.
there is a district DEIC, District Early Intervention Center, where all the high-risk registry neonates are referred to them before discharge.
So the question is, probably we are moving forward, we need to move faster, that's all. Coming to, I think this is gone. This is one thing that I have always highlighted in all forums, that all the ENT surgeons, the audiologists, they can do at least this much to see a behavioral testing. Now you will see. That's a definite response. So we know this child is hearing. So this is the least that we can, all of us have the duty to do with any children who comes with us with a speech delay. The next one, I'll go through quickly. Coming to, as Arindam said, we need to catch them young, we need to do early intervention. The question is, what is the facility in our state at the moment? What is the machinery, starting with Orindam, because they have the largest setup in terms of hearing and rehabilitation in the government level. What is the time once you pick up a child with a hearing loss, maybe if it is delayed also, how early they are fitted with a hearing aid, and are these hearing aids which are supplied, they are adequate to, cater to the high profound hearing loss
Yes,
or
sir.
not? That's a very important thing, because
Yes.
many children get hearing aid from NIHH. They are useless for that kind of hearing loss. So they do not get any stimulation. So ultimately they are auditory deprived. So
That's the biggest problem right now. We are doing cochlear implantation in the large scale in our state, and we are trying to increase day by day. But the main problem is dispensing the hearing aids, because state of West Bengal doesn't give a hearing aid to the children, and there is no policy like that. There was the IBSK scheme that was giving previously, but recently we have dispensed more than 200 hearing aid to this child by some NGOs or all that funding. But we are trying to dispense all the hearing aid from the state of West Bengal as early as soon. There is some communication and some planning also there. But till today, the hearing aid is the biggest issue, and the hearing aid quality that was dispensed from the NIHs, that is suboptimal for the hearing.
So again, that is where we are lacking behind a little
Yes.
bit. I think I would also welcome comments from the chairpersons as well. So the question is, till we have already heard from Orindam and other speakers that until we can give the child a cochlear implant, they must be stimulated with auditory stimulation. So the hearing aid has to be high powered. Dr. Mohan, I don't think in private setup it is difficult. I am also a semi-private setup, so we can manage that.
Yes, I mean,
Fitting with hearing aid.
yeah,
Till the child
absolutely,
has an
because,
implant.
see, we are at least buying time. We are at least helping the auditory pathway mature to whatever little bit it can, because that is what is going to help us. Even if there is delay in doing the implant, at least that is going to help us, get better results. So that is to be absolutely stressed. And not all people who come to us are affording. So thankfully, I have the kind of situation where we have done cochlear implants free of cost. I mean, child has come in, we have done bilateral cochlear implants, child did not pay a single penny, not even for the scans.
NGOs.
So we have that kind of funding, and we are helping them, hearing aids, upgradation, we're trying to help as much as we can. But that is through, personal contacts and personal this thing.
Even I have been able to do 20 pediatric implantation free of cost from an NGO. But that is very occasional.
Yeah, I mean,
That
we
is
need
very
more of that.
So we have seen what is the reasons of delay in our society. Last point, I think Dr. Kundu's slide, he said ignorant society. Even though these children are diagnosed and counseled at time, those children are pulled back by the taboos of the society to get intervention. This is what practically I'm sure all of you will agree. So we need to pass this message in all forums that we go and talk, all forums that even in our social forum, in our relative forum, our patients relative, they should persevere this message that this is important to do, pick them, catch them young. Because if we catch them at 7 years of age, even the best quality implant will not give any speech to them, which
Absolutely.
is been discussed.
I'd like to interrupt. I'd like to quote a case in point. Believe me, grandchild of a pediatrician, no speech, turned up to me at 3 years age. 3 years age for the first test, and that too not referred by the pediatrician. The daughter and the son-in-law, they brought in the child. How sad is that? I mean, I think we need to reach out to the pediatric society and also the neurological society, and we need to spread the message that
This
please,
is the
please
message
let
we
us,
want to spread
yes,
today. Yeah.
absolutely. That we need to work together. I mean, you don't want to be in an unfortunate situation where you know that the child is hearing loss at a very late stage, and by then the 80% of the brain development has already happened. So
actually, we have come out of that era when we started cochlear implantation. People used to say, cochlear implant, eta ki kaaj kore? Too fancy. That was the response we used to get from pediatricians. But today, pediatricians are referring us cases. Yes. Now the need of the hour is to make the all sections of society, including the pediatrician and obstetricians, to make them understand that if we cannot catch them by 4 years or 5 years, there is no point. Their life is doomed and they will be shunned in one corner of the society where they will never be able to come out to the mainstream of society where we are talking. So,
One more thing, Amitabh. I think we need to, as a society, we also need to talk to the hearing aid companies and, impress upon them the need to accessorize, to glamorize hearing aids. Today people will wear glasses, Tommy Hilfiger or Police, Diesel frame, Ray-Ban frames. They'll spend thousands of bucks on that. And take it as a fashion statement. Why don't we help people, little girls, some design on the hearing aid, so that becomes a fashion accessory.
Good point.
So
point.
this is the kind of attitude or outlook that we need to develop, and we need to talk to the industry.
Okay. In this regard, any other comments from the panelists?
One biggest problem is the giving everything free of cost. When the child or the parents spend some money for any treatment, they got this awareness and they got understanding of that thing. But in programs like in government, state or the ADIP, the biggest challenge is to make them understand what is the benefit and giving everything free. And we have some situations that patient is giving everything free, they is admitted on the day of surgery after doing every counseling, they have cancelled and go to home without doing the implantations. There's such a negative thing had happened.
That's because
recently.
of the taboos
Because
of the society.
taboos
Somebody,
of the society.
Professor Sinha.
Hello. Deafness is the second most common cause of disability in our society. After RTA, deafness is the most common cause. It is the second most common cause of disability. And to overcome this disability, it is a duty of the person concerned or family, but it is also the duty of the society also to bring the child to the mainstream of the society. And one thing we are right now facing, those institutes who have performed, as Dr. Indro, Dr. Kundu mentioned it, in ADIP scheme, the persons comes from very poor socioeconomic state of the society, and we implant these in a very nice way. But after some time, when they go home, there is some problem in the implants. And we are now facing these implant is out of the market, and the government is unable to supply any defect parts of the implant. And it is the most tragic situation. The child is able to hear, he developed his language, but now there is a complete dearth in the family. So I think we must move from our association and others.
Yeah, that's the thing. We want to create a message from this forum that this has to be done. We are not
the persons, the child who have already having the implant, but not functioning right now.
So we all have to build up some process to support these children. In our private setup, we are trying to build up some process, and we have some process in somebody has a very poor patient, cannot buy a thing, then we have some NGOs, we have some connections. So in the hospital also there is Rogi Konlan Shomiti, there are other things. So we need to approach those organizations that for this backup, the government is giving the implant, that's fine, or the hearing aid, but for the backup, for the next few years or lifelong patients to, maintain the implant if there is a breakage, if there is an accident, so that we can get something. So
Sir, 1 minute. In the ADF scheme, after the warranty is over, the manufacturing company of the implant is also not interested in maintaining or providing service. It's very important. The child has a tendency to fiddle with the wire, they break it, and after, say, 5 years, they just wonder what to do now. It is a very important point, especially in the ADIP scheme, because they go to the company with the warranty, so we can't do anything. Now where will they go? It's a very important practical problem we are facing.
Absolutely. So before we, yes sir.
Yeah, basically the pair parts are not available. The implantation that I did 10 years back, the pair parts are not available. How can we procure? Patients are having implant, but the outer unit is lost. battery is not available. So it's a tragic situation.
So anything else?
Actually, the implantation and that is a technology. So every 10 years or 5 years, there will be some upgrade. So we have to provide the upgrade to the patients also. And from the ADIP and from the state government scheme, whatever is comes, we have to try and percolate this message to the policymakers that giving one time is not the sufficient thing. In future, they have to upgrade the external device for the child also. That is a major thing.
Now we don't have much time. There is a question, just last topic that I wanted to discuss. One panelist, I want you to volunteer to talk about the advantage of bilateral implantation, which is the talk of the day. And any juniors, they would like to know about bilateral. Anyone? কে বলবে একজন একটু শর্টে প্লিজ বলে দাও I'll just show you a
So-
video and then we'll wind up.
As of the hearing aid, previously there was a single-sided hearing aid was used, but recently we have moved to binaural hearing aid for all the patients. Implantation is like the same thing. When the child is not listening or there is some hearing loss, we have to give stimulation from both the sides so that the both side of the brain and the auditory cortex can mature properly. And that is the most important thing. And this is the maximum benefit can be given in terms of localization of the sound. Whenever the child goes to the school and after some time when he will go to the secondary class or in the colleges, every time he will face some problem from the side localization or in a single-sided implant. And the most important, the second part is, as it is a device, sometime in their life the device will get some problem, and if the child has the binaural implant, at least one implant will work for that time, and child will get stimulated continuously throughout the life without leaving a single minute of our life without this hearing or anything problem. So
Okay, thank
this
you.
is why this is
I will
important.
just finish. Anything else? Yeah.
It should be bilateral simultaneous cochlear implantation that you are talking.
Not necessarily. Either simultaneous or sequential.
Sequential.
For the benefit of the juniors, simultaneous is when both ears are done together, irrespective of the age. Sequential is when 1 year is done, because if the child is too young to have a longer anesthesia and all the, or funding issue, and the child can have a second implant after 1 year or 6 months to get a full benefit.
Yes.
I'll just show you a video of one of our child who had a bilateral implant, and just to show all the things that a child's hearing becomes 100% normal. Orindam has shown beautiful video. So this is a girl who had a sequential bilateral implant, and now she is talking to her mom, who is in a actually standing in other part of the room, not close to her. And you will see her hearing and her answering and her working, whatever she was doing, is not disturbed while she is answering. So hearing does not become an effort. It's a natural hearing like us. Like I am talking here, if somebody shouts there, I can hear. He is talking, I can hear the noise. So that is the thing. I'll just show you the video, the advantage of bilateral implant.
বাবলি কি করছো?
অঙ্ক করছি।
আর করতে হবে না, ছেড়ে দাও।
না বাবা, পরীক্ষাতে না পারলে আমাকে বকবে আর মারবে।
So the question is, she is not even looking to her mom. She is continuing to do her mathematics and scribbling as she is talking. So this is the advantage of bilateral implant, in addition to working in the noise, crossing the street, getting the direction in the classroom, everything. So with this, we would like to conclude. There are so many things to discuss. So I will skip this. We have discussed these things. I think it's a teamwork. So I would just finish with this quote, that blindness separates us from things, but deafness separates us from people. These people, if we cannot do anything about their problem, they will be shunned in one corner of the society where they cannot come and communicate with us. Because if you remember the first slide I show, where the child was showing a sign language, she had so much to speak, but none of us could understand what she was speaking. And that is why we should bring this back together. We should work together, create awareness. As I said, this symposium was not about telling what we are doing today in here, but what we should do further to make these children bringing to the mainstream and change their world. Thank you very much for a patient hearing, all the audience and my respected sir. Please conclude.
Without 1 minute, is there any special workup for bilateral implant?
Bilateral?
Bilateral implantation?
No, nothing.
Nothing separate?
Same. Absolutely same.
Thank you, Amitabh, who is junior to me. So I'm very proud for you.
Thank you, sir.
For nice demonstration of these various slides and your surgery, and to bring all the speakers to conclude from the beginning to the end about the candidacy, about the investigations, about the requirement, and ultimately it is a teamwork. You have mentioned it. It's a teamwork. It is not the duty of the surgeons. It is a teamwork. And about the complications also, few complications. Thank you for your nice presentation.
I would now request all the speakers to come here to take their memento, please. Chairperson, sir, please give memento. Dr. Indranath Kundu first, being the senior most. Dr. Ramanus Sinha, sir, please. Dr. Mohan, please. Dr. Devashir Borman, please give away to, okay, fine. Actually, both of you can give together, that's better. Group photo. Dr. Arindam Das. Dr. Moina. I have the pleasure to give the memento to the chairperson.
Now I request Dr. Ramanut Sinha and Dr. Devashish Burman sir to felicitate our moderator, Dr. I request Dr. Amitabh to felicitate Dr. Devashish Burman sir. Now I would request Dr. Devashish Burman and Dr. Ramanut Sinha sir to felicitate Dr. Amitabh Roy Chaudhary, our moderator for the session of Cochlear Symposium.